In this section, we will look at the different basal insulins used in the treatment of diabetes. Prandial insulins, that is, insulin injected before meals, will not be discussed. Basal insulin is an integral part of the treatment of type 1 diabetes with intensive insulin therapy with multiple injections. It is also a common treatment for people living with type 2 diabetes when oral or injectable anti-hyperglycemic agents are not sufficient at lowering an individual's blood sugar levels. For both types of diabetes, injected basal insulin tries to reproduce as accurately as possible the insulin secretions by the pancreas of an individual without diabetes. Insulin allows glucose, that is, the sugar in the bloodstream, to enter the cells to be used as a source of energy or be stored in the liver. If the pancreas doesn't secrete enough insulin, the glucose will remain in the bloodstream and cause an individual's blood sugar levels to rise and ultimately lead to a variety of diabetes complications. As discussed, the oral and injectable anti-hyperglycemic agents target multiple mechanisms to help insulin do its job. If the targeted mechanisms by the medication are not sufficient at allowing glucose to enter the cells, there is another solution: inject more insulin into the body. Basal insulin comes in different forms. The first family of basal insulin is long-acting insulin. Long-acting insulin is injected at bedtime. To see the effect it has on you, you can measure your blood sugar levels on an empty stomach before breakfast. If your doctor wants to make adjustments or encourages you to make self-adjustments, reviewing your fasting blood sugar levels before breakfast is how you will be able to make decisions. Insulin is characterized by the time it takes to begin having an effect, or the onset time, when it has a maximum effect, or the peak action time, and how long that effect lasts, or the duration. Long-acting insulin is different in that it doesn't have a peak action time. Its effect is sustained at the same level for all of its duration. There are 5 types of long-acting basal insulin that may be prescribed by your medical team. Glargine insulin, also called Lantus or Basaglar, has an onset time of 90 minutes. Its effect lasts for 24 hours. This insulin is injected at bedtime. Detamir insulin, also known as Levemir, also has an onset time of 90 minutes. Its effect will last 16 to 24 hours. This insulin is also injected at bedtime. Glargine insulin at a concentration of 300 units per milliliter is sold under the brand name Toujeo. Its onset time is 6 hours, and its effect will last for 30 hours. Degludec insulin, also called Tresiba, is sold at the concentrations of 100 and 200 units per milliliter. Its onset time is 2 hours, and its effect will last for 42 hours. In theory, Tresiba and Toujeo can be injected at any time of the day, provided that it's always at the same time. In practice, the vast majority of people who use these insulin inject them in the evening, always at the same time. The other type of basal insulin is intermediate-acting insulin. There are 2 insulins made of NPH isophane that act in the same way: Humulin N and Novolin NPH. They have an onset time of 1 to 3 hours and reach their maximum effect 5 to 8 hours after injection. Their effect then fades, but their action is sustained for about 18 hours. These insulins are injected at bedtime. The graph compares insulin action over time. As you can see, long-acting insulins have a moderate action that lasts throughout the day until the next injection. Intermediate-acting insulins, on the other hand, have an effect that increases in a few hours and decreases, so that for the period between supper and bedtime, the intermediate-acting insulin injected the day before no longer has any effect. Now for some practicalities. The majority of people who inject insulin use cartridges and pens. Cartridges in use, that is, the insulin that is in the pen, can be kept at room temperature for up to 28 days or longer, depending on the type of insulin. Check the details on your cartridge of insulin. The time period and storage temperature will be indicated there. In general, insulin should be kept between 15 and 30 degrees Celsius, so be careful on very hot summer days or in the winter. For example, try not to forget your insulin pen in the car. If you haven't used all of the insulin within the specified time period, the cartridge and remaining insulin should be discarded. Stored insulin, that is, cartridges that have not yet been placed into a pen, should be kept in the refrigerator until use or until their expiry date. Everyone who injects insulin should be given personalized instructions. This video gives the general information, but you and your medical team need to determine the type of insulin, the dose, the precise injection times, and any other details specific to your situation. Everyone who injects insulin is at risk of hypoglycemia. It might be useful to review how to prevent, recognize, and treat hypoglycemia. Université has a complete video course devoted to the topic of hypoglycemia. In the next section, we will review proper injection technique and how to rotate your injection sites. We will now look at injection fundamentals. A good injection technique makes a big difference in the management of your diabetes. A good injection technique ensures your body will receive the amount of insulin prescribed by your doctor each time. You and your doctor may have been very thorough in determining the amount of insulin to inject, but if your injection technique is off, there's no guarantee that your body will receive all of the insulin prescribed. Before injecting insulin, be sure to have all the necessary equipment: a pen containing an insulin cartridge, a new needle for each injection, and clean hands. We'll now show you how to install a new needle onto your insulin pen. Keeping both caps on the needle, screw the needle onto the pen. Then remove both caps. You'll now need to remove the air from the needle. To do this, act as though you're going to inject 2 to 3 units of insulin. Turn the pen so that the needle is facing upwards. Press the piston down until you see liquid come out of the needle. This means that there's no air left in the needle. You can now set the pen to the dose of insulin prescribed by your doctor. When injecting insulin, inject at 90 degrees and avoid tilting in any direction. For example, if you're injecting into the abdomen, inject at 90 degrees and avoid tilting in any direction. Once the needle is under the skin, press the piston down and hold this position with the piston pressed down for 10 seconds. You could then remove the needle from under the skin. If you're using 4mm needles, there's no need to make a skin fold. Speak to your medical team about the best needle length to use. To remove the needle from the pen, replace the larger of the 2 caps. Unscrew the needle and dispose the used needle in a sharps container. The majority of people who use insulin will need to do so for the rest of their lives. Although the needles used today are very thin, the fact remains that having a foreign object under the skin every day, and potentially several times a day, can cause adverse effects. If you always inject into the same spot, this can cause lipohypertrophy, clumps of fatty tissue under the skin that feel like small bumps under your skin. Lipohypertrophy is usually painless. In fact, it decreases skin sensitivity and can make injections less painful. However, because it prevents the proper absorption of insulin into the body, it's not recommended to inject into an area where there's lipohypertrophy. To avoid lipohypertrophy, always use a new needle for each injection. Use the shortest needle that's appropriate for your situation, and use proper injection techniques. It's also important to rotate your injection sites. Adults could inject insulin in the abdominal area, the back of the arms, the thighs, and the upper buttocks. Of these areas, insulin is absorbed at the most constant rate when injected into the abdomen. Within an area, you need to inject into different sites. You need to establish a structured plan for injection site rotation. For example, if you're injecting into the abdomen, you could divide this area into 4 zones. You would start by injecting in the upper right zone the first day. The next day, you would inject into the upper left zone, followed by the lower left zone, and then the lower right zone, before continuing to the upper right zone. You could further vary these sites by dividing each of the 4 zones into 7 subzones, 1 for each day of the week. You would start closest to the belly button for Monday and move outwards as you progress throughout the week. You need to find a method that works best for you. Some people will make a small drawing and put a dot on each area they've used. You could also use colored needles. This box contains 4 colors. Each color is associated to a different zone. For example, if I choose the blue needle, I would be injecting into the lower left zone. Find the method that works best for you. And if you feel that your abdominal area is being overused, speak to your medical team about any precautions to take before injecting into your arms, thighs, or buttocks. To further avoid pain, use a new needle for each injection and use the shortest needle appropriate for your situation. It's currently recommended to use 4mm needles for most people with diabetes. Avoid injecting into scar tissue, into a mole, or into the root of a hair follicle. Use insulin that's been kept at room temperature, and avoid using cartridges that have just been removed from the fridge. As you can see, there's a wide range of medications that can be used to treat diabetes. Drugs taken orally, injectable drugs, in addition to insulin. Diabetes is a disease that evolves over time. It's possible that the medications prescribed at diagnosis may need to be replaced later on. It's also possible that at times you may feel a bit lost. Don't hesitate to speak to your medical team about any effects that your medications may have on you, or if you have any other questions. Diabetes management is a team effort, and of this team, the person living with diabetes is an important player, not just a spectator. This course has been made possible with the financial support of Roche Diabetes Care, a division of Hoffmann La Roche Limited.